And now we'll hear the chief instructor himself, Dr. SUBHASH PRASAD, a prolific cataract and a VR surgeon. He's a member of the managing committee of AIOS right now. And in every conference, you'll see him running from hall to hall delivering his presentations.
I just first like to thank Dr. Satyajit for covering the topic which was supposed to be taken over by Dr. Vibhuti, but he could not make it. And today morning he actually took this video because he was not prepared. So thank you very much. So this is the last talk of this session, the Phaco in operated VR eyes. This is again a challenging situation for anyone. We all know that the cataract is very frequent complication of any vitreous surgery, and nowadays large number of vitrectomy are being performed. And with advancement in the technology in vitrectomy also, the surgical results are very good, but at the same time cataracts are also increasing incidence. So prevalence can be up to 80% of the vitrectomy cases, and the risk factors are if there is any intraoperative lens touch, even if it is not there, if you have injected silicone oil, use of intraocular gas, and older patients or post-operative uveitis, these patients do end up with cataract early and early. In children, most of the time it is posterior subcapsular in nature, but in adults it is nuclear type of cataract which is more frequently encountered. So what are the challenges in these patients? Most of the time, the most important I would enumerate is that they have low endothelial cell count. There is high chances of deep anterior chamber which may have silicone oil without silicone oil bubbles. The journals are compromised. People often don't dilate that much. The scattered sometimes may be very hard, and a lot of these patients have PC plaque or some opacities on the capsules, posterior capsule that cannot be removed, and reduced visual potential in these patients. So there are several pre-operative, intra and post-operative considerations that has to be taken into account for successful outcome. And like in any case, detailed patient history, the nature of the surgery which the patient underwent, whether the patient having injected silicone oil or whether it was a gas or whether the cataract progressed very fast, just to rule out any posterior lens capsule touch. Pre-operative examination, particularly to look for posterior capsular tear or jonular dehiscence. And whenever possible, it is always mandatory to do the indirect ophthalmoscopy, not just to see the cataract but to prognosticate the patient, because you may have associated retinal detachment, recurrent retinal detachment, which can be missed. So patient may expect that after surgery everything will be all right, but patient won't improve, and then patient will blame you. So that is very important. B scan if the cataract is very advanced. So biometry is not an issue if there is no silicone oil in situ, but if there is silicone oil inside, then the biometry axial length actually gets changed. So you have to take into consideration that factor also. So the thing is that if there is 1300 centistock of silicone oil which has been implanted, nowadays most of the VR surgeons, they actually paste a sticker about the silicone oil, so that can actually guide the next surgeon what was the silicone oil used. So you can multiply it with the conversion factor of 0.71, the axial length, which is multiplied, and that gives the almost nearly accurate axial length measurement. So here, unlike in LASIK where the cornea was making the problem, here the axial length is making the problem in the biometric calculation. So if the patient is going for cataract surgery with silicone oil removal, then the planning, maybe the IOL power calculation may be different as compared to when the patient you still want to have the silicone oil in situ. So these patients require little bit of adjustment, but most important thing is that these patients must be consulted beforehand, that postoperative outcome may not be very accurate and you may require some adjustment of the IOL power, maybe even sometimes even exchange or piggybacks. This is just one example of the latest generation machine, the optical biometer IOL Master 700, which fairly gives accurate calculation of the axial length, provided the cataract is not that much dense. You can bang on the post-op refractive error of this was a patient who had post-operative refractive outcome of minus 0.25 cylinder spherical only. So the using the latest machines also helps in some situations. What the other problems which we encounter is during surgery, that is the problem with the anesthesia. So most of the patients must be given NSAID and cycloplegic even longer before what we give in the routine cataract surgery, so that there is no intraoperative meiosis during the surgery. Topical anesthesia but intracameral lidocaine is suggested because there is sudden deepening of the chamber that can cause some discomfort to the patient. And whenever you anticipate that the surgery will last longer, you give a peribulbar injection and sometimes GA also. So the problem in the surgery is that these patients have hypotony most of the time, so use copious OVD, very deep anterior chamber. So if you are using the gravity fed system, keep the bottle head low. But at the same time, you have to take into the consideration that if you are keeping the bottle head low, use the slow motion phaco like low infusion, low smaller lower parameters, and keep the microscope zoom little low. Corneal incision should be 2 to 3 steps. For a small pupil, you should be ready with your hooks and rings because you may require it, and standby VR surgeon is always mandatory. It's not mandatory, but always preferable. So doing capsular access in these patients may be difficult because most of the time these patients do have anterior capsular fibrosis. So just using cystotome may not help you. Sometimes you have to use Vanna seizure, and if you have the access to vitreous cutter, this vitrectomy cutter probe actually very useful in these patients where you can cut the anterior capsule, make a small opening of around 5 millimeter in the central anterior capsule, and then go ahead with the phaco. Use the dye always because the glow will not be that much good as in the normal cases. And with hydrodissection you should be very gentle because many patients they have weak posterior capsules. Phaco is always preferable over SICS, and always follow the dictum of slow phaco. Rule of thumb is that avoid applying excessive force on the lens during emulsification. Avoid reverse pupillary block and infusion deviation syndrome. And whenever possible, if you have access to the active fluidic system, that gives better outcome or better you can say the comfort during the surgery. The cortical aspiration should be bimanual because there may be a sticky cortex just below the anterior capsule at many places. So bimanual IA is preferable. IOL placement should be very gentle, and the choice of IOL should be hydrophobic or hydrophilic, or you can use the PMMA also, but silicone IOL should not be used. Large optic IOL should be used with 360-degree square edges, and plate haptics and silicone IOLs must not be used. This is a small video clip of a patient who had undergone VR surgery, and now silicone oil, even in the anterior chamber, has come as emulsified silicone oil. So just doing the cataract surgery in this patient, just to demonstrate that these patients may have silicone oil in the anterior chamber, that also creates some problem in biometry and visualization, and corneal endothelium gets compromised. So just to show that I am demonstrating this case. But phaco, again, like in any myopic patient, whatever precautions you observe, you should observe here. I will move to the next video because of paucity of time. This is a case who have undergone vitrectomy previously. You can see the port scar here, both sides. And as soon as I enter the anterior chamber, you can see that the iris, the whole lens iris diagram shifts posteriorly. This is called actually lens iris diagram posterior shifting of the lens iris diagram. That is also called reverse pupillary block. For that, you have to relieve that. You can use iris spatula below the iris, and then this will be relieved, and so the phaco will become easier. Otherwise, everything will be so deep that it won't be possible to approach the lens correctly and do the phaco correctly in these patients. I will skip this video. Just wanted to show low IOP phaco, how useful it is in these patients. This was a operated case of vitrectomy. Since there is no posterior vitreous support, so lens always try to go down, and the chamber becomes excessively deep. So using this active fluidics technology of keeping the IOP of 20 millimeter actually does not cause any fluctuation in the atrial chamber. So that is very, very actually useful and very safe. Just small video clip showing the posterior capsular plaque in these patients. After removing the nucleus and the cortex, you can see there is thick posterior capsular plaque which is not going as such, but I am trying to remove it with the Sinski, and you can very well do it some of the some of the cases. You have to just create a cleavage, and then with the use of the forceps you can take it out. But even after that, there is some opacity of the posterior capsule, so that can happen very regularly in these types of cataract. Just another 1 minute video of pre-existing PC tear in the patients who have undergone vitreous surgery. I actually landed up with the problem of there was since pre-existing rent, so the part of that thing actually went down into the vitreous cavity itself. And then before coming out in the, if you have PC tear in any situation, come out before coming out with the cutter with the IA, you have to inject viscoelastic through the side port. Post-operative care is again more aggressive because there may be more inflammation. There are increased chances of posterior synechia, secondary glaucoma, and CME. So there is need of increased and rigorous follow-up in these patients, sometimes even lifelong, like in diabetic patients. So these some of the patients you can see posterior synechia, again silicon one. So just to summarize, you have to plan these patients in advance, do proper biometry if silicon is in situ, have a standby gadgets available like sulcus, IOL, CTR, hooks and rings, and you do slow motion Phaco to avoid any complications, and these patients need regular and long-term follow-up. Thank you very much.
Thank you, Dr. Subhash, and thank you all for sitting through the session during lunch.